morning. So good. So welcome, everyone. Thank you so much for coming. We have a treat for you today. Dr. Taylor Warmoth. She is a board certified internal medicine physician, also boarded in rheumatology. So she's going to tell us all about the wonderful things that we can help ourselves with our bodies. And so I'm going to give it over to Dr. Warmoth, and please help me welcome her.
Yeah. It's nice to be here with all you guys today. It's beautiful outside, but not until afternoon anyway. So it's good that we're indoors until the wind dies down. Can y'all hear me okay? And we're good for, let's see, is that better? That volume there? Okay. So no, of course, I just didn't know with the virtual stuff too. Also, I have a perforated eardrum that popped on me about a month ago. I'm having to have it patched next week because I'm still pretty deaf in this ear. So if I am looking this way a lot, just remind me it's just because I'm trying to hear. Now I sympathize with my father for the first time in his life. So, all right. So today we're going to talk about osteoarthritis and osteoporosis. These are two conditions that I treat pretty routinely. And it's not uncommon that I will sit in the room with the patient for about 45 minutes during our first visit, just kind of going through the basics of these diagnoses and what we can learn from them and how learning about them helps us treat them better, not only as physicians, but as patients who receive medical care. So what we'll talk about today briefly, I just have introductions of each condition and then what we call the pathogenesis, or how we think that these conditions develop. Then we'll talk about some of the naturopathic options, or the more natural options to treat them, things that my patients really do like to hear about. And then some medicinal options as well, which I jokingly call them, but medicines are technically poisons. It's a chemical we're putting in the body to try and get and elicit a response. Most of the time, that's a positive response, but absolutely, we do see negative effects with chemical medications. And so we talk about in my office, the least amount of poison is the best amount of poison. And so that's something we'll get into as well. In medical lectures, you're always supposed to talk about disclosures. This is if anyone has paid me to talk about their products, things like AbbVie, Pfizer, those things. Turns out I talk enough on my own for free, and no one has tried to pay me for it to date. But just, keep an eye on that. The other thing that they'll, just to kind of tell you about myself, just my background, I did grow up here in Lubbock, Texas. I went to medical school and residency here. I met my husband in residency, and then we did something called the couples match, which forced him to propose, number one, but number two meant that we actually matched into separate training programs at the University of Arkansas for Medical Sciences, or UAMS, in Little Rock, and we did our subspecialty training there. He trained as a nephrologist. He's a kidney doctor here in town. And then I did my rheumatology training there over a couple of years. And then once we were able to and get our boards done, we actually moved back to Lubbock. I've got family here, and his is in Atlanta, and there's no way we're dealing with that traffic. So that's just kind of my background. That's how I have come to be here. We've been back in Lubbock about 4 years now, and are happy to call this place home. So what are our objectives over the lecture today? This is in the course guide that they sent out, but truly I just want to cover everything regarding the diagnosis of both arthritis and osteoporosis, kind of explaining what the differences are between those two conditions. Let's include what symptoms patients have, what risk factors patients may have, and then what potential options we have for treatment, including anything from dietary changes to full-on, infusion medications. So before we start, I just want to go over the basic anatomy of a joint. So this is the most basic picture we can get of a joint, which is where two bones meet and we are able to bend. So every place in our body where we can bend, there is some kind of joint there.
She turned the light so there's not a glare.
Okay.
Sorry, I interrupted.
Yeah. All righty. So this here is a joint. And so what you can see here is the top and the bottom. I don't know, can y'all see the mouse if I move it? Yeah. So this here is a bone, and here's our other bone. And we're going to get into actual bone structure in a moment. But what I care about more than anything as a rheumatologist are these little lines of tissue on either side. These things are called the synovial membrane. And that's truly the tissue that holds bone together. So you've got to think of it as it wrapping all the way around, kind of like a roll of tape. And this membrane produces fluid. And so this fluid is called, very cleverly, we've named it synovial fluid. It's produced by the synovium. And what that does is it helps cushion our joint. It helps provide a little bit of a fluid pocket in between every joint. And in most of my conditions, my autoimmune diseases, this thin little piece of tissue is where disease begins. Rheumatoid arthritis, psoriatic arthritis, this is where this starts. But in osteoarthritis, where we truly see the problem is with this cartilage right here. I am sure at some point you have talked to a friend or talked to a doctor yourself and heard the words bone on bone. And when we look at osteoarthritis joints, which I have a picture in the next slide, you'll see that the problem is with this cartilage. The purpose of cartilage is to cushion joints. Now, fluid can only do so much. Joints are going to push together, right? At points in our lives. We stand up from a chair quickly, or we, do jumping jacks or run or whatever. Joints are going to, things I don't do, but these joints will rub together at points. And so cartilage is a very smooth tissue that helps cushion the bones from rubbing on each other. But unfortunately, cartilage is a one and done product in the human body. We are not capable of reproducing cartilage. So when you look at a joint that starts to develop osteoarthritis, what we see the loss of truly is the loss of cartilage. And so this happens with a couple of things. We'll kind of get into it. But as we lose cartilage, our body notices these changes in pressure. What used to be a very smooth and gliding joint is now a little more rough. And we start to see the development of something called osteophytes. And so while our body cannot grow cartilage, it's very good at growing bone. If any of you broke bones as a kid, I broke my arm when I was in 3rd grade. It was healed within 6 weeks. I mean, that's pretty cool if you look at the x-rays before and after. But bone growth is not an incredibly organized process. And so the bone does not grow in this nice, smooth structure that you see with the cartilage here. It grows in atypical lumps, bumps. And what we're truly trying to do here is increase surface area to decrease pressure. But this leads to the bumps that you see on the sides of your fingers. This leads to the widening knees. This leads to those joints starting to twist in unusual patterns, because as bone grows, those joints kind of start to jut out. So what causes this? What causes the loss of cartilage? Well, that's living life. Okay, living a life worth living is what leads to osteoarthritis. So every bike accident you had as a kid, the high heels that I wore for all of my 20s, every jar you've ever opened induces arthritis at the base of our thumb here. Then we have, bigger traumas, car accidents. I do see lots of patients who come in with chronic back pain or hip pain, neck pain after something like a motor vehicle collision. And then good old genetics right there in the middle there. So I always tell some of my patients, but I was a ballet teacher for many years before I went to medical school, and my hips are kind of destroyed, but I did that on my own, right? I was doing all kinds of leaps and jumps and landing on the ground, and sometimes not too gracefully. But if you look at my hands, ballerinas, we don't do anything but stand like this. And so my hands should not have any arthritis in them. I've not lived a very physically demanding life. But if you look at some of my knuckles, they are twisting already. And I've got one little knuckle here that's already got its first little bump. If you look at my dad's hands, he's got those bumps on every single finger. So genetics, even though I'm in my mid to late 30s, genetics has already started to come for my hands, and I've already started to develop arthritis. Now, the important thing is even though these changes may be happening, they are not always painful. So when we talk about x-rays of a patient, their x-ray does not always match the patient. In fact, studies have shown only about 50% of the time can I look at an x-ray and then look at a row of patients in a lineup and say, these have to be those person's knees. Because I can have x-rays from patients that look absolutely terrible. They're like, well, they're not that bad. I'm fine. And I'll have patients that come in and just hurt all day, every day, and their x-rays are not that terrible. But it doesn't mean that the pain is not there, because we can only see so much on x-ray, right? And so just because I have this lovely little bump on my finger, I remember it bugged me for a few days when it first appeared, and it hasn't hurt since. My hips, every time it gets cold. So what are some of the things we can do about arthritis? Well, there's no preventing it. This is the tax of living a good life. Okay, this could be the tax of living a not great life. I joke that you could have been the, I don't know, it seems like the royals in England don't have it that great nowadays, but you could have been the king of England and been bedbound and had food brought to you every day of your life, and you still would develop arthritis. But what are the things we can do to try and help it once it does start to develop? And so I talk to my patients about there is this very large spectrum of treatment, all the way from very, very natural things to the more medicinal options. And combination therapy is always best. So anything from I do these 3 natural things and this one a natural thing, and that's the combination that works for me, that's fantastic. But what we talk about first and foremost is nutrition. Now, I joke with my patients, but I tell people I was born a woman, but I became a doctor. And I grew up in a generation watching them call Britney Spears fat and, body shaming lots of women. And so I always say it's incredibly important to me that my patients, when we talk about diet, they understand that I am not talking about weight at all. Okay. People of all weights get arthritis. Even people with anorexia get arthritis. And so weight is not a huge factor here. Inflammation is. And so when I talk about the Mediterranean diet, I talk about it because this is one of the best anti-inflammatory diets we have at our disposal. Now, if you Google inflammation and diet, it's going to tell you all about the autoimmune protocol diet. That's not a bad diet, but it is incredibly strict. It has a very high failure rate, and it introduces a lot of what we call food fear, which I tease, but it's like me with my heartburn. You can just say the word ice cream, and I just get a little anxious because that's the only thing that's ever made me think, oh, we need to go to the hospital. This isn't normal heartburn. It was. Pepto helped. But food fear is just, it's not a healthy relationship to have with food. And so the Mediterranean diet that I like is going to be much more of the what did Jesus eat type diet. What do they have available to them in the Mediterranean? So this is going to be more seafood, chicken, and turkey. It was a lot harder to kill a cow 1,000 years ago. They did not eat a lot of red meat. And so if you think about it truly, the lighter meats seem to do well. And that's hard to do in West Texas. Red meat is fantastic here, but all things in moderation. If you're basing your diet more with the seafood, chicken, and turkey, that's a fantastic start. Additionally, we look here, you see all of your little grains and fruits, those kinds of things. They talk about cutting out processed sugars. So the things that you're going to find in any candy aisle of the grocery store, anything with high fructose corn syrup, those kinds of things do not seem to do great for us. However, natural sugars do really well. There was actually a study done somewhat recently about the types of sugars we have been putting in our coffees, the stevias, the splendas, those kinds of things. And it looks like these artificial sugars that they gave us thinking it would help with diabetic blood sugars and helping overall, two kind of counterintuitive things happened. Number one, these sugars or fake sugars were associated with increased inflammation. And number two, these false sugars are sweeter than natural sugar. And so it actually increases our cravings for additional sugars. And so a couple of years ago, I transitioned back from my Splenda to regular sugar. And I noticed I went from needing 2 packs of sugar to 3.5, just to keep my coffee at that level. And so I've worked very hard. I married a Colombian man. He drinks his coffee black. I've worked very hard to wean my way down to like 1.5 packs of sugar. But when we go to Colombia, no one puts sugar in their coffee. They're all very offended when I ask for sugar. But I'm still proud of myself for having weaned down that much. But processed sugars seem to be what they avoid here. So I tell people, if you've got a sweet tooth, it's okay, but go for chocolate chip cookie or a brownie instead of a Twix bar or, something with a lot of gelatin in it. The last thing that they really harp on in the Mediterranean diet is cooking oils. So in particular, what they typically use in this diet is going to be olive oils and avocado oils. These 2 oils are highest in omega-3 content, which if you see the vitamin aisle, everybody's talking about their omega-3s now. All other cooking oils are high in omega-6. Omega-6 is pro-inflammatory. And so this is easy to do when you're at home. It's very easy for me to say, okay, I'm going to, fry up some. My husband made shrimp last night. We did it in olive oil. Great. But the second you start buying any kind of food that you didn't make yourself, it gets a little more difficult. And so there are actually some nutritionists on social media that I really, really like. There's a guy named Bobby Parrish, who is on both YouTube and Instagram. I'm sure he's on other stuff, but that's all I peruse. But he talks about, he takes his 4-year-old daughter into grocery stores and he says, okay, we want potato chips. Which ones should I pick? And she can look at these bags and tell you that this is the brand we like because these potato chips are fried in avocado oil, whereas all other chips are made in canola oil or vegetable oil. And so I just keep telling myself, okay, if his 4-year-old can figure this out, surely I can. But he makes it very simple. He shops at Costco. Heck, every now and then he'll even say, I'm going to go look at the clothes. And he just wanders off and comes back with sweatpants. But these are changes that with enough time, and with enough repetition become very, baseline, very much our standard behavior. The other thing that we'll talk about just briefly here about oils is with olive oil, there's a couple different types out there. One that seems to do the best, which is available actually at Costco, they have it, but I typically find it at World Market because I don't want to buy 3 bottles of olive oil. I just like my one, is first cold pressed olive oil. And so what this is it is the olives collected from the first harvest of the year. The theory is that those olives are the most slow growing and thus have the highest nutritional value. And then they extract the oil from these olives via a cold press system. Normally they use hot heat presses to get these oils out of olives. However, that does something called denaturing the proteins or destroying those proteins. And so cold pressing olive oil, sorry with my peas, cold pressing olive oil seems to actually help maintain the nutrients in those olives. And so for cold first pressed olive oil seems to have the highest nutritional value, to the point that I have now had 3 or 4 of my patients tell me that they actually just take 2 tablespoons of cold first pressed olive oil every day, and they have noticed significant improvements in their pain. One of them puts it in her oatmeal every morning. One of them puts it in a smoothie. One of them just takes it like a shot, which I just can't imagine. But you know what? It's at least something now that every time I'm cooking, I instead use cold first pressed olive oil. Now I'm using, heat on it, so I'm probably destroying some of those proteins, but it's available at Costco or Market Street or Costco or World Market is where I have found them here in town. The one I like is a little orange bottle with a little horse on it, but it's not much more expensive than just general olive oil at this point in time. So then we've got some of the more natural anti-inflammatories available over the market. One of those is turmeric. Turmeric is a fantastic all-natural anti-inflammatory. It is a spice we use in cooking quite frequently in my home. And then you'll see there it's paired with some ginger, which we'll kind of get into. But turmeric is available in a couple different formulations. There's just the spice. You can get that, in any seasoning aisle at the grocery store. It'll be right there in between saffron and, cumin, that kind of thing. But turmeric has really great all-natural anti-inflammatory properties. So the problem with just the spice is that means you're having to add it to at least 1 meal every day, and that gets a little repetitive. So I love it in my husband's paella, but I don't want to eat it every day, especially because I don't want my house to smell like paella every day. So there are a couple other options available, including tablets, which are probably the easiest to do. You can get these at any grocery store, any nutrition store, that kind of thing at this point. And then there's liquid turmeric. You can do that one of 2 ways. Here I've shown you just the drops, but they also have liquid turmeric at Costco that comes in like almost a little miniature bottle of orange juice. And it kind of tastes like a spicy orange juice, and you literally throw it back like a shooter once a day, and it seems to help. Now, the potential side effects of turmeric, there's 2 or 3, just so you know. It is all natural, but so is arsenic. So we need to keep in mind that all natural does not mean all good. So turmeric can cause a little bit of heartburn. It is a spice. And so what you'll see with many of these combinations is that they also have ginger in them. The idea behind the ginger is that it's supposed to help prevent heartburn. Some of these will also have cracked black pepper in them. The idea behind that is there have been some studies that show it helps with absorption, but that's kind of up to you if you want to try that or not. Additional potential side effects of turmeric are kidney stones. People who are prone to kidney stones have found that they have developed a little bit more on turmeric. So if you're going to take these supplements, just drinking a lot of water is recommended, which we should all do more of anyway. And then the third is it can actually thin the blood just very slightly. This isn't something that I would worry about in an average person, but if you are known to have surgery coming up, they'll typically tell you to stop this a few days before surgery just to help not thin that blood up too much. Then what you'll see over here is the next supplement that some people notice good effect with, which is tart cherry extract. Cherries actually carry the same chemical as Tylenol. It's been shown in multiple studies to be incredibly efficient at helping people during gout flares. It reduces inflammation quite well. It's also been shown in a couple of studies to be helpful with sleep. So if sleep or pain or something that, tend to bother you, this is such a simple vitamin to try adding. The only side effect I can think of this one is that it is tart. It's tart. But other than that, I don't imagine any side effects with something like this. it seems to do very well. Just typically we'd use it for gout, but it's also beneficial in arthritis. Of course. Mhm.
Kidney disease, you said kidney.
Kidney stones, yes. So absolutely. So her question was, is turmeric safe in kidney disease? Being married to a kidney doctor, he has not raised any concerns about this one. As far as anti-inflammatory goes, this seems to be the safest one to use in patients with renal disease. I think once you get more to that stage 5, stage 6, and what I've always been told is there are 6 stages of kidney failure. I think people hear stage 4 and they start to get very worried. There's 6 stages, not just 4. Once you're in that stage 5 or stage 6, they're going to stop almost everything you're taking anyway. But stage 3 or 4, I think it'd be perfectly fine. Of course.
It's okay to take part cherry and turmeric.
Yes. Yes, those ones are compatible. The only, truly the only all natural thing that I really don't like patients taking is St. John's wort. That one interacts with a lot of stuff and can really screw with the liver. All right, so then there's topical things. There's natural things we can put in our body to try and help, but then topical agents do seem to help a lot as well. We've got some natural ones here and then some medicinal ones that we'll get into. So the first thing that people typically know the most of is that Voltaren gel. Voltaren gel contains a medicine called diclofenac. Diclofenac is the exact same type of medication as ibuprofen. But the idea here is that if you cannot take ibuprofen for some reason, you're on a blood thinner, you've had ulcers in the past, you have kidney disease, this is not getting in your bloodstream. It has less than 9% systemic absorption. So unless you bathe in this stuff, you should be just fine applying it topically. Now, diclofenac in this formulation is available in 1%. It can be compounded. There are multiple pharmacies here in Lubbock that will make it up to a percentage of 10%, but that runs around $70 to $100. This stuff is $9, $12 over the counter. Now, one other thing I have more recently learned is that there is a 2% diclofenac gel, which is available in the US by prescription only. And I used to prescribe it all the time. It was called Pensid cream. And about 2 years ago, it got bought out by a new pharmaceutical company. It went from $25 a month to $1,400. So if that doesn't sum up American healthcare, I don't know what does. But this product is available in Mexico. In fact, it's a little bit stronger in Mexico. It's 2.32% in Mexico. It is made in the exact same, yes, thank you, lab, by the exact same people, but it's shipped off to Mexico because that's where it's available over the counter. Now, would I tell you to take any antibiotic or blood thinner you found over the counter in Mexico? No, but this is a cream. Like worst case scenario, you get a rash. You stop using the cream, it should go away. So what I joke with my patients, but I tell them is if you or any of your friends are going to Mexico for spring break and they offer you a souvenir, say, yes, bring me back 2.32% diclofenac gel. It's available over the counter at any pharmacy. They're going to probably, it's Mexico. They're going to be in a pharmacy anyway at some point. That sounded so mean. I'm so sorry. Sounded more harsh than I meant. Then we have things like arnica gel. Arnica gel is made from arnica. This is also an all-natural oil available from plants. And I know that some of this stuff sounds a little woo-woo, but I ask people to remember that we get opium from the poppy flower. And look at all the problems we have made with opium. But we can absolutely use all natural options and still see actual physical benefits from it. And so Arnica seems to do very well. I say more for muscle pain, but muscle pain typically follows joint pain pretty closely, right? If you've been on a plane or in a car for a long time and the back hurts, when you start to rub those muscles, that's when we start to notice relief. And so Arnica is very good at that. Additionally, just so y'all know, my other favorite tidbit with Arnica is it helps a lot with bruising. So if you've, I don't know, I have once in my life taken a headbutt from my Great Dane. I got a very nice black eye about a week before med school graduation. This is what, it was awful. Called my mom just in hysterics. It's fine. We found this and it helps a lot with bruising. Then there's Asper cream. This is also available over the counter. It is more prescription-like. This is true medication, but it's still, over the counter and nothing that you're going to hurt yourself with. But typically what Asper cream contains, and there's a couple formulations, is it's going to have some of those anti-inflammatories in it, like the diclofenac. It also has a cooling agent like menthol, or camphor, which is a tree oil. And then usually Aspercreme will have a little bit of lidocaine in it as well. Lidocaine's the type of numbing medicine you get at the dentist. And so patients will typically do very well with a cream like this, especially if you like cooling agents. Then over on the right, depending on how you feel about it, even in Texas, a lot of CBD-based products are legal. Okay. Obviously, we do have stricter laws than a place like New Mexico or Oklahoma or most of our surrounding states now, but CBD products are still legal. The caveat to that is that no one can say these products are not going to make you fail a drug test. Okay, because it depends when they run a drug test on you. Are they testing for CBD or are they testing for THC? And those are not always very well defined in these tests. And so it is possible that you fail a drug test on these medications. So I typically recommend the topical agents over the ones you consume. Now, if you're never worried about a drug test, heck, go get the gummies over at Drug Emporium. They have the Delta 8 and Delta 9 products there, but it's not something I do myself just because that's basically my worst fear. But these topical products, I actually have used this one on the far right. This is the arm I broke as a kid. I do have some arthritis in there, but this particular line is called BioSpectrum. It's available at Drug Emporium for like $27. It is a roll-on, which I like because then you're not touching it with your fingers, and I'm still paranoid about what if I get it in my mouth or in my eyes, or am I gonna, accidentally get myself high or something. But what this one contains is, it's legitimately my biggest fear. What this one contains is actually just hemp. They don't even try and wean this down. But just a quick background, the way we get CBD in this state is only from the hemp plant. So hemp is different than actual marijuana plants. Hemp typically only contains CBD and microscopic amounts of THC. So you can roll that up and smoke it, and it's really not going to do anything. Whereas with marijuana, it has the CBD as well as THC, and that THC is what leads to the high that many concert goers desire. What this does, though, since it's from the hemp plant, it has microscopic amounts of THC in it. And so it is legal in the state. And there are still some borderline studies, but still some that show that this is beneficial. The reason I like this one is it also contains that lidocaine numbing medicine, the menthol, the cooling, and camphor, which is, again, a tree oil that seems to help with pain. Then another one that I really like, when I worked at the VA back in Little Rock, this was actually something they could get from their physical therapist. They could sent home with one of these machines, but there are really good studies, and this is still recommended as first line, both by the American College of Rheumatology and the American Society of Surgery for the Hand. And anytime medical doctors and surgeons agree on something, you know that it must be pretty beneficial. So this is called paraffin wax, and it's very similar to candle wax. If you ever stuck your finger in a candle as a kid, this wax peels right off. It doesn't tear your hair out or anything like that. But you can buy these machines for about $40 on Amazon. Sometimes they've even seen them at Goodwill, and it melts this wax. You dip your hand in it for a couple of coats, and then you'll see you can apply this plastic bag here, throw a warm towel around it, give it 10 to 15 minutes, and then that wax peels right off. The reason that this is recommended is I see all the time my patients come in and tell me, my hands hurt until I run them under warm water in the morning, or my hot shower. And heat is obviously a very, very good management option for pain. But wax holds on to heat for a much longer amount of time than water. So two things come out of this. We're able to get longer treatment, and we do not have to raise the temperature as much. Because if you notice, we'll catch ourselves raising the temperature higher and higher and higher, and it's because we're trying to get that heat to retain longer. So this actually seems to do really well for patients with arthritis. You can do hands, feet, and even elbows or wrists pretty easily in this. Obviously, this gets very difficult with larger joints, knees, shoulders, backs. And then the last thing I do send a lot of people for is occupational therapy. This seems so mundane. The patients hate it, but 6 weeks later, they do typically feel a little bit better. And so this is going to be very simple things like, here are beads, pick them up and put them in the bin. Or open this jar using this new assistive device and show me how you're going to do it. Because so many of the things that we do on a daily basis aggravate the arthritis, especially in our hands. And so the most common site in the world for arthritis is at the base of the thumb right here. Both of us, all over the world. If you think about it, every baby we've ever picked up, every lid we've ever fought with, every zipper we've pulled or button we've pushed through a hole that was just a little too tight for it, all of that induces arthritis at the bottom of the hand here. bottom of the thumb. And so we should use these assistive devices already, like not even because we need them, but to help prevent the development of arthritis. I know this is so bad, but I don't open my own water bottles anymore. I make my husband do it. And every time I just act like it's because I'm not strong enough. And that gives him a little ego boost. It protects my hands. It's a win-win for both of us. But this actually does do very well for patients. And so even that's part of why I send patients to occupational therapy is there is a very good support system there in explaining that these assistive devices are not only helpful, but they're also preventive. So we don't have to worry about things getting worse. We might help prevent some of those micro traumas that lead to additional disease. So that's why I like therapy. Then we have actual medication options. Okay, so starting with a class of medications called the NSAIDs or the non-steroidal anti-inflammatory drugs. There are things you can get over the counter like Aleve or ibuprofen, and then there are prescription strength versions like Celebrex. Celebrex was very big on the news in the 90s. I don't know if y'all remember back then, but Celebrex had a cousin named Vioxx. And Vioxx was my mama's favorite drug. She's got a bum hip, and she was pissed when they pulled it off the market. But the reason it got pulled was because there was a theory that it was associated with increased cardiovascular disease. Celebrex, which works the same way as Vioxx, was able to do their studies and show that while there was a very slight increase, it was not significant enough for the drug to be ruled dangerous. And so while this drug is slightly associated with increased cardiovascular disease, it is incredibly helpful for pain and can be taken either on an as-needed basis or on a scheduled basis of 2 doses a day. As far as Aleve and ibuprofen, those are both available over the counter. Aleve can be taken twice a day, ibuprofen up to 4 times a day. And so these both do pretty well for patients in a pinch. Of course.
I'm kind of joking, but I do want your opinion.
Of course.
The only time I ever used Aleve,
Mhm.
I found out I was allergic to, I guess, that Nexo.
Uh-huh.
And the way I found out was after I took it, I started
Itching.
and my whole body itch. It made my face red.
Mhm.
When I took it was my wrist had been hurting for a couple of weeks.
Mhm.
So just a very nagging pain, and it seemed like nothing else would get it. Now, Miracle, and I'm not saying it's the drug, I think it's pain went away.
Mhm.
Never came back.
Okay.
I never used Aleve again.
Yeah, I wouldn't.
And I was like, see, the pharmacist told me to use Benadryl to counteract.
Mhm.
Gee, can I use Benadryl to counteract it? Use it
In a pinch, right? Yes. So this happens a lot with my rheumatoid patients because they're on medications like Humira or Enbrel, which require injection. And it's not uncommon for them to get an injection site reaction. I have one who, bless his heart, he came in yesterday. It was about the size of a paper plate or a dinner plate. And when I said, we can change meds, he said, no way. He goes, my arthritis is controlled for the first time in 6 months. He's psoriatic arthritis. He goes, my rash is gone. He goes, so I do this injection once a month, and for 3 days I have a big old rash, but it's fine. So what I recommend is in a pinch, pre-medicate. God, the P's, I'm sorry. Pre-medicate with Benadryl and Pepcid. Like the one you take for the antacid, because Pepcid is also known as famotidine is the generic name. It works on histamine as well. And so typically when we see itching or hives or those kinds of reactions after taking medication, it's due to a histamine release. And so taking both of those medications about 30 minutes to an hour before can help reduce the risk of reaction. And if you have problems, you can take additional doses either right after or again at bedtime, just as kind of a prophylactic thing. We actually do this in our infusion centers as well. Anytime someone comes in for an infusion, before they get it, 20 minutes before, we give them Pepcid, Tylenol, and Benadryl. Depending on who's driving them home. But those are great options for if it's not, throat swelling, tongue swelling, those are never again, don't take it. But yes, if it's okay, my stomach hurts for a few hours after I take it. There are moments in your life. Yeah, there are moments. Yeah, there's moments where the costs outweigh the benefit. And then there's moments where it's the other way around. So
Do it. I was really generally I don't
Yep.
but about it is my husband came home with the Benadryl. He said, if you hadn't called me, I'd know you had a problem. He said, your face was so red. I
Bright
could tell
red.
you had a problem.
Yeah.
Of course, when I called the pharmacist, of course, what's the first thing you're afraid of? Am I not going to breathe?
Mm-hmm. Mm-hmm.
He asked me on the phone, he said, are you breathing? Yes, you're fine.
Then you're good. Yeah. You sound like my mother when I was growing up. No one's bleeding. You're all breathing. You're fine. Don't go back to go outside. Yeah, absolutely. That worked.
Not that the others didn't work somewhat. It's just, I was like,
Mhm.
"Darn, I
Yeah.
can't."
Yeah. Mm-hmm.
One, how much of it can you take?
Very good. So that's actually our next slide here. Aleve, what we recommend is 2 tablets 2 times a day. And ibuprofen, it's always going to be in these 200 milligram tablets, but we recommend a max dose of 800 milligrams 4 times a day. My kidney husband would kill me for saying either of those. So less is more with either of these drugs. And so that's what we're going to talk about here. This is now medication. Medication comes with side effect. Medication comes with cost. And we talk all the time in medicine about the cost versus benefit ratio. What potential gain, what potential loss goes on here. So when I have patients chronically on medications like this, and don't get me wrong, I do. I got to keep Daniel employed somehow. When I have patients on prolonged medications like this, I require laboratory studies every 6 months to make sure I am not killing their kidneys. In particular, with these medicines, we worry about renal function or kidney function. It is something I see at least on a monthly basis. Someone comes in, their kidney numbers have jumped, and I call them, I say, you got to stop the Tylenol or the ibuprofen. We got to hold the Aleve for 3 weeks. Come in, we'll recheck the numbers. If they've come down, okay, we can go back on it. If they haven't, we're done with it. The other thing that these medicines are known for is gastric ulcerations or stomach ulcers. This is an unpleasant experience for anybody involved. And so even if you don't have heartburn, I put every single patient of mine who are on these medications on a PPI or a proton pump inhibitor. That's going to be Nexium, Prilosec, pantoprazole, Dexilant, whatever your flavor may be. But I put every single patient on one of these daily. That has additional issues with it, but let me explain why we do this. Of the patients who develop ulcers while on chronic anti-inflammatories, 50% of them say that they never had heartburn. They never had symptoms. They never knew they had a problem. And then one day they woke up with either severe stomach pain or vomiting blood. And so even if my patients go, I don't have heartburn, I go, I don't care. If we're going to take this medicine every day, we're taking this one every day too. There are all these, studies. I think anytime a medicine reaches 30% of the United States, all of a sudden, all of these articles start coming out about how terrible they are. And so PPIs had their year a couple of years ago. I think Ozempic will be next. But what they talked about with these was there was some concern for kidney issues. We have not found that to be true in follow-up studies. The one thing that this can affect is bone density. But what do you know? I treat that too. So honestly, if in the scheme of things, if that means 10 years from now, I have to put you on a pill once a week, but you get 10 years of pain relief, then that is a cost benefit ratio I'm willing to do. But we have a discussion about it with every patient because it's their body, their choice. Tylenol, you asked about this one earlier. So Tylenol works a little bit differently. Tylenol is what we call an analgesic. So it doesn't actually affect inflammation at all, but it has been found to be very helpful for pain in particular patients. In addition, combination therapy seems to do very well, which we'll come right back to it, but that's where this came from. Okay. So Tylenol is acetaminophen, and the maximum dosage of this that's recommended is 1,000 milligrams 3 times a day. The bottle's going to tell you 4 times a day is fine. In a pinch, that's okay. Long term, you don't want to go over 3 times a day. And that's because this medicine can affect the liver. So Advil and Aleve is kidneys, Tylenol is liver. And so there's a couple different formulations of Tylenol over the counter. My favorite is just Tylenol extra strength because it's 500 milligrams. So that's very easy. You take 2 of them at breakfast, 2 at dinner, and you're done for the day. Then there's also Tylenol arthritis. Tylenol arthritis is an extended release tablet, but it's a 650 milligram capsule. So you're having to do like 1.5 of these to get your 1,000 milligrams. Some people do take 2 at a time, but that really means you can only take this twice a day instead of 3 times a day because you're getting close to that 3,000 milligram limit. And then I have lots of people talk to me about Tylenol PM. Perfectly fine. But all this is acetaminophen and Benadryl. It's a lot cheaper to just buy both of the generics over the counter. So Tylenol PM is fine, but this is branding more than anything. This is just acetaminophen and diphenhydramine or Benadryl. Now, I talked about combination therapy earlier, and that's where this came from. This is actually relatively new on the market, but what this is Tylenol and Advil in one pill. The thing that's weird, truly, with this is the dosing. These are very low doses of these medicines. Only 250 milligrams of Tylenol and 125 milligrams of Advil. I told you the normal pill is 500 milligrams and 200 milligrams. So these are lower dose, but that may be great because if there are patients out there who get by great with 1 or 2 of these tablets, you're getting the combination of treatment, but you're requiring lower doses overall of medication. And so this is a great option for people who take both. But just know that if you're doing 1,000 milligrams of Tylenol and 800 milligrams of Advil twice a day, you're going to need a lot of these pills to actually meet that same dosage. And because this is a brand name medication, it is going to be expensive. So it's more money, but it may cut down the actual number of pills you take, which people like. Then we have actual prescription strength stuff here. So this is a weird pitch. Buckle up. Cymbalta is an antidepressant. It's an old one. We don't really use it as much for depression anymore. We've got better things that you see all the commercials for, right? Wellbutrin, Zoloft, Lexapro. You remember the Zoloft commercials? The little egg followed everybody around. Wellbutrin. But Cymbalta is pretty old, and it works a little bit differently than your newer antidepressants. So this one is what is known as an SNRI. It works on 2 hormones that the brain uses to transmit signals, including serotonin and norepinephrine. The norepinephrine is where we think things come big here because that's one of the stress-related hormones and has been found to be increased in patients with pain. So this medication is fantastic for patients with chronic pain. It can be taken once or twice a day. It is absolutely a very good friend of the kidneys and the liver. It doesn't seem to cause toxicity to either of those. The biggest thing I've seen on lab values is it can drop your sodium level, your salt level a little bit. So I have had the distinct pleasure of getting to be the doctor that calls the patient and says, hey, you need to eat more salt. When have you ever heard that from a doctor? Right? I also talk about cheese a lot, which is the next half of this lecture. We're going to talk about eating cheese, which I know the cardiologists don't love me doing, but they can shush. I'm keeping them employed. So Cymbalta is a really good drug just for chronic pain in general. They actually, when they came out with the new medications for depression and they started switching people over, people started complaining of pain. And so what was unique is they said, well, let's try it again. And they put them back on Cymbalta. Their pain got better. Then they did this in studies with people who had never been on these medications before. Their pain got better. So this is now actually FDA approved for the indication of osteoarthritis.
You said it's okay with kids.
Mm-hmm. That's why I like it. Then, and so this works on like kind of a hormonal type signal in the brain. Then we have things that work on actual nerve transmission. So if you imagine nerves as telephone wires or electrical wires, they can really only send one signal at a time. And so these 2 medications are kind of old anti-seizure meds. The idea here was to stop the electrical signals that were getting sent. But these 2 medications have also been approved in treating chronic pain and work on the nervous system. You've got to be a little careful in patients who already have kidney disease with these medicines because they can be sedating. But other than that, these are very safe medications that we don't see typically cause issues with kidney, liver, bone density, anything along those lines. So these are called gabapentin and Lyrica. Now, the one thing you need to know about Lyrica, it's a slightly more advanced version of gabapentin. And I'm just realizing that box is in Spanish. But Lyrica is now a controlled medicine in the state of Texas. They did that in 2016. And the reason is that someone got a whole bunch of tablets of it and they tried to make something in a kitchen, wink, wink, that we do not want on the streets. And so a meth house blew up And the state, just like they did with Advil cold and sinus, said, okay, you know what? You got to show us an ID to get this. So this medicine's not addictive. It doesn't have a street value really, but they don't want you going to the pharmacy and picking up 600 tablets of it because they're worried about you making meth in your kitchen. So this one does require a actual physician's order to get it sent. My nurses can't send this in for people, whereas gabapentin, that's not an issue. Then we have narcotics. These are the, last resort before injections or surgeries, right? So tramadol, Tylenol number 3, these are ones I write for somewhat routinely. And then there's the big guns, which I send them to someone else for if we need to get to that point, your oxycodones, hydrocodones, anything you hear about on the news. We use these medications as sparingly as possible, but quality of life is very important, right? Truly the focus of medicine should be more about quality over quantity. And so I can't tell you how many times I'll have an 82-year-old in my office that's like, I don't want those pills. I'm like, but if it makes you feel better for 12 hours of your day, wouldn't it be worth it? And usually with their family's help, I can convince them to at least give it a shot. And I can tell them, look, this is for emergencies only, or for when you're on vacation, or for when, you've helped take down the Christmas tree the day before, whatever. These do not have to be everyday meds. The same shoulder I broke, I dislocated my 3rd year of medical school. So well over 10 years ago now, I still have that bottle of tramadol in my pack, and it goes with me on vacations, just in case. But with all of that said, I mean, these are good medicines, but you have to be careful with them because of the risk of addiction. Then the last quick thing about this, what else can we do for osteoarthritis? The final steps after all of this has been tried and failed would be injections into the joint, typically with a steroid or with something called hyaluronic acid, which is like a gel that helps with the joint. And then the other thing we could look into is actual replacement. People ask me all the time, when is it time for replacement? When you say so. Okay, the answer is when you say, this hurts too much, I want this joint fixed. Or this is affecting my day-to-day life too greatly. I need it taken care of. And so my example of that is my dad had a hip replacement last August, and he would not have done it had we not been going to Columbia in October to see my in-laws. And I made them go with me, so I had someone to speak English with. And I told my dad we were going to have to fly through Miami. That airport is massive, and the train has been broken for years there. And so I said, Dad, just for the first half of the trip, please let me put you in a wheelchair, because it's a good 3-mile walk from this through customs and then back to the next airplane or whatever. And I said, you're going to be miserable all week if you walk. I mean, I know you can do it, but you're going to be miserable. And he heard the word wheelchair and realized that that was actually something to be considered. And he had his hip replacement done at the end of August, and walked like a champ through that airport in the end of October. So all of that said, when is it time? Pain, which he had been controlling with medication, okay, or when the impact on your life is too great, that's when it's time. Not when your neighbor tells you, not when your doctor tells you. And most of the time, doctors are not going to tell you, oh, you need this done. They'll just say, put it on the radar and call me when you're ready. When you're ready, that's when it's time. All right. Any questions about osteoarthritis stuff before we move on? Sorry, that was long. Okay. So on to osteoporosis. So osteoporosis is the thinning of bone. So osteo meaning bone, porosis meaning porous. And so you can just kind of see a basic picture here. On the left, we have quote unquote normal bone, but you can see it's got lots of actual bone with these little air balls or air bubbles throughout it. And then as osteoporosis develops, its first stage being called osteopenia. Osteoporosis is when the bone gets very thin. So this is actually a picture of bone on an electron microscopy. So you can just see what we have here are these bridges of calcium. Okay, and so these bridges in a quote normal bone are nice and thick. They are very frequent. You can see lots of connections between these two. This is why when you fall off a curb, you don't break a bone every single time. But as osteoporosis develops, you can just see how easily this bone can break. You can actually see a small fracture there. Now, the important thing to know about osteoporosis by itself is it doesn't really hurt. The walls are thin, but they're still standing. And so osteoporosis is not painful. Osteoarthritis is. Osteoporosis is not a quote unquote problem until you have broken a bone. And we now have to talk about, okay, are we doing surgery? Are we doing a hip replacement? Are you in a cast? Are you in a wheelchair for 6 months? That's what we're trying to prevent. So we try and prevent osteoporotic fractures by treating it with medication most of the time. So I want you to think briefly of Texas water. This is not my faucet. I feel like that's important to point out, but we see calcium buildup occur. And the important thing to know about calcium buildup is that when calcium sits for a while, it gets really brittle, right? I mean, I could reach over and scrape this off pretty easily. And so, or like the lining of a pool, whatever. I just remember as a kid, like sitting at, I drove my mom crazy. She's like, I'm paying for a pool membership and you're picking calcium off the sides of the walls. But what we do is, because bone is made primarily of calcium, is that we are constantly turning it over. And so we don't want to let calcium sit too long, it gets too brittle. And so two cells are involved in this process here. We have one cell called the osteoclast. And what the osteoclast does is it comes in and chews up the pieces of bone. And then we have the osteoblast, which is the second cell, and they come in and they fill the gaps. And the idea here is that that way those calcium, bridges are constantly overturning, remaining strong. Vitamin D is involved in this process as well. And so the thought is this is how we keep our bones nice and strong. Two things happen though. As we age, as genetics takes hold of us again, as estrogen leaves the picture, the chewers start to eat a lot more quickly and the builders get a lot more lazy. And so what happens is we start to consume our own bone more quickly than we can replace it. And this is the guideline of treatment for osteoporosis. Okay, depending on the severity of disease, we either try and kill these guys or motivate these guys. And so how we test for that is by doing something called a bone density scan. I would hope that most people in here have had a bone density scan before. If not, give me a call after this. But this is a bone density scanner. And so you can see this woman's laying on this little, kind of cushioned bed here. What this machine is technically an X-ray, but an entire bone density scan uses less radiation than a single chest X-ray. So the first thing we do is have them lay with their legs up like this, and we scan the low back, the lumbar spine in particular. And then the second stage is she'll lay with her legs flat. This will come down slightly, and it will look at both of her hips. In the hips, we look at two things called the femoral total and the femoral neck. And I'll just show you real quick. This is a hip bone-ish. And this tiny little area here, where it goes between this kind of bulky area and this skinny area, let's see, is called the femoral neck. So you can see it's just thinnest right here. And so that's where most fractures happen. But people call me a lot and they'll go, well, I think they screwed this bone density scan up because they're talking about my neck and they were nowhere near my neck. I'm like, no, it's the femoral neck. So even though we use that word, it's still regarding your hip. And so what we get after this scan is a report that looks like this. This is almost exactly what my scores look like here, or my machine produces here. And so it's a little blurry, I'm sorry. But what we look at, you can see, is this is the spine. And this is why people will ask me, well, didn't you get an X-ray? I'm like, well, yes, but not good enough to actually see bone. What we're measuring here is density. So we send a little beam of radiation through these bones, and basically we count how long it takes to come out the other side. And that results in something called bone mineral density. And what we're estimating there is how many grams of bone you have per cubed centimeter of bone. And then we convert that. We do something with statistics basically called a standard deviation. I don't know what you guys remember of your statistics training classes, but standard deviation was one of my least favorite things. But what this talks about is basically we take every person your age who's ever had a bone density scan that we have the results of, and we compare your numbers to theirs. And if we say this is average, then you have people who are more dense than average and people who are less dense than average. And what we talk about is how many deviations do we go until you're severe. And so what we look at here is this thing, we've renamed it the T-score, but all this is standard deviations. And so a T-score of minus 1.0 to minus 2.5 is going to land you in the osteopenia category. So thin, but not terribly so. Increased risk of fracture, deserves treatment, but doesn't have me scared. And then if you are minus 2.5 or less, that's the osteoporosis category. Okay, so that's all this shows me here. So if we look at this person's T-score here, you can see that their worst T-score is in their lumbar 2 vertebra. That's this one. And that T-score is minus 2.3, which lands them pretty solidly in the osteopenia category.
Got two questions.
Okay.
Osteopenia, becoming osteoporosis, and what are the treatments for osteopenia?
Perfect. So we'll get right into that right now. So her first question is, how do you prevent osteopenia from becoming osteoporosis? The answer truly is treatment, but that's what we're kind of going to get into here. So first off is who's at risk. Okay, so anyone, what they talk about typically now is women over the age of 65, men over 75, but truly we're finding this much younger nowadays. I think that's part of, as we've fought insurance companies a little bit more, they're letting us do this as soon as women hit menopause. And I'm getting women in their 50s that are already in that osteopenia category. So age is the number one risk factor. Smoking, tobacco, big risk factor. Alcohol and actually caffeine consumption, more than 3 glasses a day, has been associated slightly with increased risk of bone density issues. Truly, I understand caffeine because it changes metabolism a little bit. Alcohol, what I think honestly is the risk factor there is people who are drinking 3 or more glasses of alcohol a day are typically more prone to falls, and falls lead to fractures. So a previously broken bone, now I don't mean you got rear-ended and broke your collarbone or what I did falling off a trampoline and broke my arm. That doesn't increase my risk. It's if you've had a simple fall and you broke something, that is an indicator that you are likely already in that osteoporosis or osteopenia category. And then I am doomed because of my mother and grandmother. They both have a very strong family history of osteoporosis, and that's just something we can't fight. And then the other thing is low body weight. I think what they talked about here was 126 pounds or less was low body weight associated with increased risk of bone density issues. So what do we do if we get this first scan and you're in that osteopenia category? I have a lot of patients who come in, their first scan has been done, they have mild osteopenia, and they do not want medicine. And I don't blame them because these guys come with a hefty price tag, both physically and actual in cash. But the first 2 things that every, especially American woman needs, we are far more prone to osteoporosis than men, but truly what we recommend is vitamin D3 and calcium. Vitamin D3, they recommend 800 to 2,000 international units a day. This is a medicine that you can technically overdose on. So I have patients coming in taking 10,000 units a day. I'm like, whoa, 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 let's check your levels and see if that's necessary. But the ideal vitamin D level on your test is going to be around a 50. The labs will always say 30 to 100. Truly, we want it between 50 to 70, just so you know. Typically, perimenopausal women do fine with an 800 to 1,000 units of vitamin D3 a day, and then postmenopausal women need about 2,000 units. I personally actually take 4,000. I've had my level checked a couple times, and I just am not someone who keeps their vitamin D on board, apparently. Vitamin D does require the intestine to help absorb it, and then you have to convert it to an active form. So some people just don't hold on to it as well as others. So this level really should be customized with your primary care doctor or with your endocrinologist or rheumatologist, who are the 2 other docs who typically treat osteopenia and osteoporosis. Then calcium. We need about 1,200 milligrams of calcium a day. You're going to get 150 without even trying. Just eating food, not worried about what you're getting. You're going to get 100 to 150 milligrams that way, but you need to get the rest with some form of a supplement. A glass of milk has 300 milligrams. If you get the lactate vitamin D plus calcium, it has 500 milligrams per cup. An ounce of cheese, 300 milligrams, particularly Brie, Gouda, Blue, and Parmesan cheese. Those are the 4 best ones. I'm not ever going to eat blue cheese, but I'll eat Brie and Gouda all day. If it crumbles, I can't do it. Orange juice with calcium added is about 300 milligrams for a cup, and yogurt, 300 milligrams for a cup of yogurt. So if you can stand eating a cup of yogurt with a glass of orange juice every day and having 2 ounces of cheese throughout your day, lunch, wine board later, whatever, that gets you your 1,200 milligrams. But what I tell patients is that can get a little hard to track. It's a little tedious. So I tell people, take your calcium in the night and just at the end of the day think, okay, I took a glass of milk, that's 300, yogurt, that's 300. So I only need 1 pill tonight because the average pill is going to be 600 milligrams. And you can kind of decide how much you need. There are 2 forms of calcium out there that are recommended currently by the American College of Endocrinology. That's going to be the calcium carbonate, which is Tums, and calcium citrate. Calcium carbonate is better absorbed with 2 big caveats here. If you take a PPI, that's Nexium, Prevacid, anything like that, that calcium is not absorbed. Lots of people, including myself, take PPIs. Okay, so that's a problem. Problem number 2, this medicine is known to cause kidney stones. Okay, I waited, okay. Calcium citrate, on the other hand, not quite as well absorbed, but actually usually helps prevent kidney stones, depending on the type you have. So I typically recommend calcium citrate, even though it's a lower absorption. It does seem to actually be a bit safer and more tolerable. Now, a lot of patients complain about calcium causing constipation. That's why you find a lot of these supplements also contain magnesium. So if stomach upset is something you're dealing with, get the kind that also has magnesium in it. It will help prevent that. Now, there's a lot of new studies coming out about calcium, either from oyster shell or from algae. It's still calcium, so in my mind, it should still do you some good. We just don't have the studies backing that up yet. Bone growth and bone loss are very slow processes. It's going to take us 10 to 20 years before we know if they're actually any good. But that's step number 1 for preventing this from developing or preventing it from progressing. The second thing that has shown to do very well in preventing the progression of or even helping improve bone density is movement, particularly weight-based movement. So we're talking yoga, walking, Pilates, something with a weighted vest, something with weights in your arms, weights wrapped around your wrist, something like that. And then sunshine helps as well. That's the most natural form of vitamin D you can get, but obviously it comes with its own risks, the main one being skin cancer. So the official recommendation is 10 minutes of sunshine a day on as many areas of skin as you can legally expose. You can go to your backyard, I guess, but you don't want to, get arrested and be like, the doctor told me I needed more vitamin D. I don't know what to tell you. I got a script in the car. I can go grab it for you. 10 minutes with about SPF 8 or less. So the dermatologists don't love that recommendation, obviously, but sun exposure helps with a lot of things. So then there's the prescriptions. These are the true quote unquote cure, albeit temporary, for osteoporosis. And so we'll get into those briefly here, and then I will let you guys leave. So let's talk about what prescription options are available. This is how I teach my residents about the classes of osteoporosis medications. This is the most text I put on any slide. So there's 2 classes here, the anti-resorptives and the anabolics. What you remember, hopefully, from that slide with the chewers and the eaters, or in the builders, is that these ones, the anti-resorptives, are exactly what they sound like. They kill off the chewers. The anabolics sounds like anabolic steroids, but don't worry, it's nothing like it. That's just the name we gave them. These are the ones that help and energize the builders. They help them build more quickly. They help them build more correctly. They help them do their job. There's actually one in here that does both, which is this guy here. We'll talk about it in a second. But within these 2 groups, they then have these kind of subsets. So we have the bisphosphonates, which we'll go over a little more in detail in a second. But bisphosphonates are by far the oldest and most commonly used drugs for osteopenia and osteoporosis. They come with a pretty lengthy list of side effects. We'll get into it. So you have to be the right candidate for this kind of medication. This is not something I send everybody else out on, but it's a good option. Then we have the very cleverly named class of the non-bisphosphonates. And there's 4 meds in here, Prolia being the big one. You'll see commercials for this all the time still, I'm sure. Hormone replacement therapy and Evista. These 3 medications are actually indicated for treatment of osteoporosis or osteopenia. Calcitonin is there if you break something. There are studies that show this helps with pain reduction for at least 6 weeks after a fracture. So I have given this to a couple of people, and they're always very grateful because pain improves and they're not on narcotics, which is nice. Then we have the anabolics. We have one that works on the parathyroid hormone. It's important you hear the word para in there. Again, medicine, we're not super clever at naming things. We have the thyroid gland in the neck. That one's someone else's problem. I don't deal with that. That knowledge is gone. But right behind the thyroid gland are 4 little bitty glands that we have named the parathyroid glands, just to keep everyone nice and confused. But those glands control things like calcium and bone metabolism. And so those guys are very important to me. Then we have something called the SERMs. This stands for selective estrogen receptor monologue. So what these ones do, we'll get into in a moment, but they work on estrogen receptors. Oh no, wait, Avista's the SERM. Oh, I messed it up. I made this myself. So it's not a SERM, I'm sorry, but there's ones that work on another type of antibody in the body. We'll get into it, but ignore that. SERM is not right. So let's talk first about bisphosphonates. Bisphosphonates, like I said, are the oldest one on the market. Okay, there's a couple different ways to take this. There's about 4 or 5 formulations of these. The oldest one is on the bottom right there. It's called Fosamax. The other name for this is alendronate. I am sure you know someone on this medication or have been placed on it yourself. There you go. So Fosamax is a once-a-week medicine that stops bone resorption and allows your body to catch the heck up. This medicine reduces risk of fracture by anywhere from 30 to 60%, depending on what area of the body we're talking about, hips or back, but it is a great med. You see bone growth on this medicine. That's good news. That reduces the risk of fracture, and that's the entire goal here. This medicine is taken usually once a week, 70 milligrams, and it has some complications with that, which we'll talk about after the other 3 here. Boniva is another one that's called abandronate. Abandronate can be taken once a month. And interestingly, if you ever watched Netflix's Grace and Frankie, which is one of my favorite shows, they actually go to Mexico in one episode to try and get Boniva for all of their friends cheaper because they can't find it in the US for cheap. My only problem with it is they call it Bovina the whole episode. I'm like, it's not Bovina, it's Boniva. Bovina sounds like bovine, which would make me think of animals. But maybe it was like a copyright thing, but they called it Bovina, but it was Boniva. And then there's Actonel. Actonel is also a once a week medication here. And so it just kind of depends on the patient, which medication you'd like to try, which one your insurance says you're supposed to try first. I will tell you, it is very frequent that I try and put patients on one of the fancier medicines, and the insurance says, no, they have to try the cheap stuff first. And this is probably the most aggressive I get with insurance companies because there are multiple studies showing if patients are advanced, putting you on one of these first makes all of the other medications not work well. So they are like dooming you to have continued disease that doesn't respond to other medications. And so this is actually, I have gone once to court, which I thought it was a peer-to-peer. It was not. Like I walk in and there was a judge. And I was like, oh, with Humana. And I won. I was very excited. It's still to this date my biggest victory. But it's something that we see. So these medicines come with a host of side effects. And so let's say, I feel like it's a bad rule if you have to break it to deliver good care. So there are some bad rules out there. But let's say that you come into your doctor and they tell you that the insurance has said you have to try one of these medicines. All you got to do is tell them you have one of these issues, and all of a sudden you're not a candidate. Okay. Dental problems. The biggest concern with these medicines is something called osteonecrosis of the jaw. That is a big fancy word for dead jawbone. Okay, it's a problem. It is painful. It is a surgical issue. Everybody's pissed off. You are having to see a dentist who's mad that they're having to treat this because it doesn't respond well. You're mad at the doctor because they gave you the med. The doctor's mad at the medicine and probably mad at your dentist because they should have warned you you had problems with your teeth, blah, 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 blah. Everybody's mad. This happens in 1 in 50,000 people. Knock on wood, I have never seen this. And statistically speaking, I never should. But this makes me nervous enough because one of my best friends in med school is now a OMFS surgeon. So after med school, he must have really hated himself. He went to dental school. And then you do fellowship in this oculomaxillofacial surgery. So he is the guy who gets these patients. They all come to him because they need bone grafting into their jaw. And these meds, he basically says, if you get clearance from your dentist first, you should be okay. Now, what does clearance mean? It means you go in for a routine visit and you tell them, hey, this crazy blonde woman wants to start me on this medication. Is that okay? And so who is at risk for this? People who are going to have their jawbone exposed to air. So people who need teeth being pulled, people who need implants being placed, or patients who have severe gingivitis in which their jawbone might be exposed to air. Typically speaking, it is safe to get root canals or cavities filled and definitely routine cleanings on these meds. But you want to be careful because this is a 5-year course of treatment. And so if your dentist says, oh man, no, this tooth, we're going to have to pull it in a year, I tell patients, do that first. Let's get the jaw healed, and then we can consider these medications. But this med, as well as almost all of the meds on the market, are associated with this risk, and we don't want to risk your jawbone. That's just dead jawbone is just awful. The other reason you heard me, or the other side effect you heard me say, is this is a 5-year treatment. You should not go over 5 years. Why? Because there is something called atypical fracture of the femur. Oh, I didn't put it in there, dang. Atypical fracture of the femur is the entire thing we're trying to prevent, but it happens in 1 in 100,000 people on the med, so 0.01% chance. But this is typically going to be in people who take therapy for longer than 5 years. I've seen it once. She was on therapy from someone else. She had been on year 13 before she got sent to me, and they said, well, it's so weird. She broke a bone. I was like, is it? What happens here is that the femur actually fractures. That's the big long bone in the leg. Now, it's not something so dramatic as you were just standing there talking to your friends and all of a sudden bone is sticking out of your leg. It's that patients come in and they say, man, my thigh is really hurting, or maybe my groin. Patients will complain of the groin. And that is a oh crap moment in medicine, because the first thing you do is you x-ray both legs, because if the fracture has happened on one side, there is a 20% chance it has already happened on the other. And this is a surgical emergency, well, not emergency, but a surgical fix. We're talking giant rod in the leg, big metal bar. And this happens almost exclusively in patients who take this medicine longer than 5 years. So we do a 4 or 5 year treatment, and then you take what we call a holiday. That's very British of us, but you take a 1 to 2 year holiday. We repeat your scans. And if we need to, then we do this again. That 1 to 2 year break or holiday takes the chances of an atypical fracture back down to 0. That's all the time you need. And then if we need additional treatment, if you've lost what we gained, we just do it again. That's it. The last side effect of this, and this is the most common one. Now there's 2. Achy bones, but that's truly growing pains. That's kind of a good sign. But sometimes it's too much. And if it's too much, then we try a different medicine. The other side effect, though, this is the big one, that if you tell your insurance, I can't do this for this reason, this is what's going to get it approved. These medicines can cause something called esophagitis, which is significant inflammation or burning of the esophagus. If you have chronic heartburn, or if you have difficulty swallowing, these meds are immediately not an option for you, okay? Because there's one other problem with these meds. Our stomach does not absorb them well at all. And that means they need to be taken on an empty stomach. And what sucks worse than telling a patient, this medicine is going to give you heartburn and you got to take it on an empty stomach? So the answer to that, or the, thing we try and do with them, is we tell them, while you take this medicine, you need to drink a full glass of water and you have to remain upright for a half hour. That's a huge impact on your life. I tell people, okay, do it on Sundays while you're getting ready for church. Just don't have your coffee. When you fall asleep at the pew, you can tell the pastor it's my fault. And she wouldn't let me have my coffee. I'm sorry. Just do your glass of water, get ready, and then, half hour in the pew before you, start drinking your after sermon coffee and donut. But that's kind of where this one comes from. So the most common medicine on the market, it does really well for patients. It is cheap. It is easy. This is I think Fosamax is free under most insurance plans, or $4 a month, if not. So they're good drugs. They just come with a list of side effects. And so they can only truly be used in the right candidate. There are IV versions of this. So if the only thing that prevents you from taking these is heartburn, then they can give it by IV. And there's one really nice thing about that, which is that it's once a year. It's pretty nice. One time a year. It's called a reclast, RECLAST. The problem is it lasts a year. So this Fosamax, you're taking that once a week. Let's say something happens, you fall and chip a tooth and they want to pull it. Okay, hold the drug a month or 2 and then we'll do that. I've had it happen once. A patient got her infusion in January. Something happened. I don't remember, but in February, the dentist calls. He says, we need to pull a tooth. I was like, nope, you got to wait until January of next year. You need it out of your system. Yeah. So this is the problem with this one. You are committed to that drug for a year. So if there's side effects from it, or if you need dental work done, it's a problem. Now, it does reduce the risk of fracture slightly more than the ones by mouth, which is nice. It reduces risk by about 70% instead of 60%. But it just kind of depends on the patient. I do have patients on this. They do well on it. But again, they've got to be the right candidate. And I need something from their dentist that says they should be fine. Go ahead and give it to them. The other thing I'll say, last thing on this, I've just noticed, and this is completely anecdotal, there's no research indicating this, but the once a week medicines do better than the once a month. And I truly think that's because I'm supposed to give my dogs flea and tick medicine once a month. I don't think I've done it since December. I mean, it's just something we forget so much more frequently. And so I like the once a week meds. I've seen better results with the once a week meds. I know it's more annoying, but just medically speaking, if someone wants these meds, I typically push them towards the once a week. Then we have calcitonin. I briefly touched on this one, but calcitonin is actually pulled from salmon, and it's truly just a nasal spray. You use it in one nostril once a day and the other nostril the other day. This has been shown to do the most benefit for people right after a fracture. So with a back fracture or a hip fracture, you can put patients on this for about 6 weeks while they recover, and it significantly improves their pain. So I've done this twice because thankfully people are not coming to me already broken. They're coming to me to prevent the broken. But both times it was astronomical, night and day within a few days, how much better they felt. So that felt pretty good. Then we have the hormone replacement stuff. Estradot, this little spray here. You've got to be careful with this spray because it goes on your forearm. You don't want to hug anybody for a little bit or you're going to give them a hefty dose of estrogen. This happened to my mother. She took her dog to the vet. She's like, I don't know why his nipples are so big. And they figured it out, but she would hug him every morning and walk. He was a Great Dane, so she'd just reach over and yeah, she was just rubbing her estrogen all up and down his chest. He was fine. We figured it out. But these meds do help reduce the risk of fracture. Now, these are one of the only meds that can be taken in combination with the other medications. Otherwise, we don't want to mix them at all. You don't want to be on Fosamax and Prolia. But this one is okay to mix in. Okay, so anything hormone related, because obviously there's additional benefits here. It helps with skin, it helps with postmenopausal symptoms. It helps, there's this huge pendulum swing on if it's good or bad for the heart. I don't know. I don't remember where we are right now, but it's meds that people are going to end up on for other reasons, but there's that added benefit. This one reduced the risk of about 30%. So not the best med on the market, but it's something. Then we have Prolia. I've put some of my own family members on Prolia, so it's a drug I like, but there's a couple issues with it as well. So again, you got to be the right candidate here. My friend who's the OMFS surgeon has told me this is the medicine he sees the least amount of jaw problems with. In fact, I think he said he's never seen jaw problems with this one. But this is a shot. It goes into the back of your arm and it's done once every 6 months. Really safe drug. It works on an antibody in the system. It's actually a monoclonal antibody here, and it helps kill off those cells that chew up bone. One big problem with it, if you miss this medicine by 2 months, those cells wake up with a vengeance and they undo everything we have done within 2 months. The risk of back fracture skyrockets within 2 months of missing a dose. So this medicine is lifelong. Once you start it, you do not stop it. Now, there are some studies. They're like, okay, well, what if somebody's bones get so good that we want to wean them off of it? What could we put them on something else for a year or two and see how they do? And I'm down with that. I've done that for 1 or 2 patients, but I don't have the studies yet. So we're going for it. We're stopping the med, whether it's because their insurance changed and now it went from free to $700 an injection. That's happened once. Or one, she's like, I just don't like it. I don't want to be on it anymore. Okay, let's figure out how to get off of it safely. So this is a lifelong medicine. The other issue with this one, no, that was it. It's lifelong. It can be expensive. Please don't ever, just never go for an Advantage plan.
It's the one I had to wait 5 or 6 months after my last injection.
Before you could do this. Yeah. So this one, actually, the data now shows that it's safe to get dental work on this done. Obviously, I'm not the one pulling your tooth. I'm not the one taking any risk. But our guidelines now say, and we have a very nice, uniform letter that gets sent out to dentists that says you can do dental work 1 month before you're due and then postpone the shot by 1 month. And that's more than enough to keep it safe. But it just kind of depends on who your dentist is, how big the procedure is, how nervous they are, how nervous you are. There's a lot of factors that go into that.
Just couldn't even.
Oh, yeah. No, they're terrified of Prolia. I'm like, there are so many worse things I can give you than Prolia.
Difference between $150 procedure and
Mhm.
$2,500.
Yeah, that's just chump change though. I'm sure you had that just laying in the closet somewhere, right? Yeah. Evista. OB-GYNs love this one for big reason. It does help with bone density issues in the back. It does not do much for the hips. That's one big thing to know. But Evista is a once daily pill, very mild side effect profile. This is the one that works on estrogen. This reduces the risk of breast cancer and not insignificantly. So if you have bone density issues, particularly in the back, and if you have a family history of breast cancer, this is a fantastic medication for you because it's going to increase bone density and decrease your risk of cancer or recurrent cancer. I have patients who have already had one round, and we put them on this to help prevent recurrence. It's a hormone kind of related medicine, so it can cause hot flashes. That's about it.
Doctors tell me that there's a heightened risk for taking stroke.
That's with Evenity, which we'll get to. Yeah, another E. But so Evista is pretty good. It's yeah, just typically it's hot flashes are the main ones with this guy. Then we have, these are the parathyroid hormones. So now we're into the anabolics. These guys run 20 to 40 grand a year prior to insurance. It's a complete battle to get patients approved for these, but in severe patients, these are my absolute favorite drugs on the market for a couple of reasons, which we'll get into. But these two medicines are the only ones that can say with 100% certainty that they do not cause any issues with the jawbone. So let's say you come to me with borderline osteoporosis or bad osteoporosis and you need dental work done. These are absolutely the guys for you. In fact, studies now show that they help you recover from dental work, which is awesome. So dentists still are a little nervous because I don't think they're, reading my journals. I'm certainly not reading theirs. But these ones actually help the jawbone recover. Couple big problems. And this Tymlos reduces fracture of the spine by 86%. By far the best numbers on the market. Forteo does the hips. Big reduction in the hip fracture. But two big things besides the cost and Forteo actually did just go generic this year, so that's been helpful. This is a shot, a subcutaneous injection similar to an insulin pen, an EpiPen, all these weight loss drugs that you see people taking. And you got to do it every day for 2 years. It's a commitment, a big commitment. You travel, this has to go with you. Forteo has to go refrigerated. Tymlos is at least okay out of the fridge for 30 days. But these are drugs that you're going to need to be very committed to for them to work. They're also not free of side effect. It's a hormone we're giving you. It's parathyroid hormone, but it's still a hormone. And so we do see what we call tachycardia with these. Patients feel that racing heartbeat for about 20 minutes after they take it. A couple of theories on that. The main one is, oh, well, it's a shot. Of course, your heart rate goes up. Well, yeah, but come on, after 2 years. Because in our textbooks, parathyroid hormone should not affect the heart rate at all, but who knows? What I will say is these drugs are eliminated from the system within about 20 minutes. So other than that, they're not severe side effects, but I do have patients complain of headache and nausea with these as well. Then the Evenity shots. These ones work on a particular antibody to help completely kill off the chewers and motivate the builders. This is the only medication that does both. This medicine runs about 27 grand a year, and it's 1 year's worth of treatment. It's given in a doctor's office. It's 2 shots once a month, every month for 12 months. Side effects. This one is notorious for causing injection site reactions. So we see big knots and nodules that occur under the arms. And then this one did get its black box warning about a year ago for increased risk of heart attack and stroke. So people who have a strong family history of that or a personal history of that are not great candidates for this medicine. Now, the big thing with this one and these two, they're not one and done treatments. Once you complete these, you need to go on one of the others for a couple of years at least to help maintain that growth and keep it there. But I tell patients our ideal growth on treatment is 1 to 3% per year. I have seen with these 3 medicines, people gain up to 22%. One caveat, bone density does not always mean reduced risk. And so Evenity, even though I've seen it decrease or increase bone density by up to 22%. If you look at the original studies, it only reduced risk of fracture by 50 to 60%. Now, they studied this medicine in the worst of the worst, the patients who had already broken a bone twice. And when you've broken bones twice due to osteoporosis, the risk of breaking it a third time is 100%. It is not an if, but a when type question. And so this medicine reduced their risk of fracture by 50 to 60%. So in those groups, that sounds fantastic. Taking you from a guarantee to a coin flip sounds pretty nice. But these medicines originally had better data in fracture reduction than this one. But this one is sometimes, it depends on the insurance, truly. That's when I tell them we'll just toss it all and see what comes back. But those are kind of the drugs we use. Here it is. So yes, the big concerns were those osteonecrosis of the jaw, and this bottom part is actually an x-ray of an atypical fracture of the femur there. So you can see it's not some dramatic thing, but it's an oh crap moment, because I don't know if you can see well on the screen, but there is it's all the way across the bone. It's what we call a spiral fracture, and this is a surgical fix every time. So there we go. Any time for questions? Yes, ma'am.
Online, you're being asked to elaborate a little on the reasons to avoid Medicare Advantage plans.
Because they're terrible. So Medicare Advantage plans, if you just go with general Medicare, it covers almost everything without prior authorization requests or without referrals being necessary. Whereas Advantage plans, you are responsible for 20% of all costs. And so when I'm giving you a drug that is $20,000, Medicare covers it in full. But an Advantage plan will require you to pay 20% of that every single time. So my patients on like Prolia get it for free or for $70, depending on what supplement they have. My patients on Advantage plans, it's $1,200 to $2,000 an injection. Additionally, things like getting into rehabs, if you ever, do have a replacement and you need rehab for it, it's much, much easier to get in on a typical Medicare plan than it is an Advantage plan. Advantage plans also requires far more involved prior authorization processes. They typically deny peer-to-peer requests, whereas if I can get on the phone with another doctor and tell them, here's why I'm doing it, I can typically get a med approved on a peer-to-peer within 2.5 minutes. You can't even get one available to you with these other Advantage plans. What about you? You got any ideas on anything else to add?
Yes, me.
Mm-hmm.
That's what I've always heard. My mom, though, is a retired teacher.
Oh, yeah. Yeah, there's not much choice there. Yeah.
But she's 97, and so she's been on it a while.
Yeah. Yeah. But yes, ma'am.
About K2, my doctor recommended
K2, yeah. So vitamin K in particular, the studies don't demonstrate that it helps bone density itself, but it helps with the absorption of vitamin D. So it's absolutely okay to get one of these. We'll see these ADK vitamins. So that K, the thought is it helps absorb vitamin D a little bit better. Yes, ma'am.
How often should you have a bone density scan?
How often should you have a bone density scan? So, of course, the answer always depends on it, whatever your insurance says. But the recommendations currently are to start scans at age 65 in women, 75 in men, and they should be done every 2 years until you have known osteoporosis or high risk or are on active treatment. And then they should be done every year. I do. I like mine very much. I have a GE Hologic. So, and the thing is just like a quick caveat, a couple of years ago, the government cut funding for bone density scans. Or cut reimbursement for it. So bone density's primary care doctors used to keep these machines in their office and hire someone to operate them. When they cut reimbursement, we literally couldn't afford to keep them in our offices anymore. The amount of electricity they draw, the salary of having to pay someone to be there to do those scans. So they stopped doing these scans. And guess what happened? Fractures skyrocketed. Thankfully, in our office, that's all we do. So we have been able to, and we have an x-ray tech there who does all of our imaging as well for x-rays, that kind of thing for arthritis patients. So we break even, like barely even, with 4 doctors and 3 nurse practitioners in our office. But we've been able to keep ours. But you see like Covenant Diagnostic Imaging just closed. A lot of the private docs in town are not doing them anymore. So it's basically us and Arrington right now. And Arrington's taking like 4 or 5 months to get people in for their scans.
I just had one, and they said if I didn't have Medicare, it's going to be $900.
Okay,
Oh,
we charge $50 cash at our
Yes.
office for bone density
That
scans.
was at Joe Arrington.
Oh,
so-
Lord.
So I'm like, oh,
That's what they told my mom actually too. And I was like, no, she's
Yeah.
64, your insurance will pay for it.
I would've.
Okay. Oh, right. Okay. So I am at Arthritis and Osteoporosis Associates. It's right off at 80th and Slide behind what used to be J&M Barbecue. Now it's a soda shop, which I do venture over there frequently, but there's our phone number and our website is Arthritis Lubbock if you need it. Not typically, no. They don't, the insurance itself doesn't require referrals. Our office does, just so we can get demographics, your phone number, that kind of thing. And then, we can kind of prep, okay, what are we actually seeing you for? Because I'll have, in the beginning, I'd have people show up and they said, well, I'm here for my kidneys. I'm like, okay, that's the wrong Warmoth. I'm like, I am very sorry you waited 4 months for this appointment. Let me make some phone calls, see what I can do. Oh, yeah. Yeah. And the nice thing is then you don't need insurance referrals. So with like Medicare Advantage plans, you have to get a new referral every 6 months. So it happens all the time that a patient shows up for their routine visit and their referral's expired and they have to reschedule because they can be self-pay, but a lot of people are just, would rather wait.
Taylor,
Yes, ma'am.
if we're unfortunately on, and I do know that because I'm a retired teacher, unfortunately on the Medicare.
Mhm.
If we came and needed or wanted a phone,
Mhm.
we could pay you ourselves and not.
Yeah, so
Private pay.
we do private pay bone density scans on our patients. So anyone who's established in our clinic can come in. Otherwise, it's a little hard for us to interpret the scans if we don't know the patient, know their risk factors. So we do have to have at least one visit with you to get it done. But absolutely, yeah, we charge $50 cash if the insurance doesn't pay for it. Other questions? Yes, ma'am.
We need a referral to get in with you. What do we tell our doctor?
Oh, if you need a referral, you just tell them, hey, I want a referral. Typically, it'll help us if you tell them why, say, my bones hurt or I want to get checked for bone density. And so that way they can actually send it over with a diagnosis. Most insurance companies will require a diagnostic code. But yeah, that's all you got to do. And we've got, like I said, 4 docs at our practice and 3 nurse practitioners. I would trust any of them with a family member of mine. We're taking new patients. I don't know. It's like a group. Any other questions today? All right. Well, y'all have been an absolutely fantastic audience. Thank you for sticking with me through that.